So we're going to have a whirlwind tour around joint replacements in the wrist joint. So I come from Wrightington Hospital, the home of the hip replacement, and that's a picture of John Charnley. And this is what he thought about upper limb surgery in general. So we don't know whether this is true, but this is what he used to feel. But I'm sure that he would have been truly delighted with the formation of the Asia Pacific Wrist Association and for what it stands for under the visionary leadership of PC Ho and then Greg and all the other presidents after him. So there have been lots of these joint replacements that have come and gone. They were essentially spacers made of pyrocarbon. What I'm going to focus on is the bits that probably will be important for the future and where we have the most experience. So that would include the thumb replacement, the wrist, and replacements around the ulna. And we'll talk a little bit about the bridge prosthesis, which we are using for post-trapezectomy problems. So we know, as far as base of thumb arthritis is concerned, that essentially 1 in 5 men and 1 in 3 women will go on to develop this disorder, and a significant number of these will require treatment surgically. We know that trapezectomy and its various forms work well. It really is the gold standard, but you have persistent weakness, shortening, there's a potential for collapse, a long recovery, and then there's the 6 to 8%, depending upon which paper you read, of problems. If you look at the continent, if you look at Europe, essentially, and this is slightly dated, a dated chart from 2017, it shows how joint replacements in the thumbs have really taken off. And you can see where trapezectomy lies right at the bottom. And now this is a more recent graph, and you can see that these are being done in the thousands. So to put a number on it, in the UK in 2026, it's projected that we will probably do between 2,500 to 3,000 joint replacements using just the touch prosthesis. So this is just one manufacturer. Those are the projected figures. Looking at the timeline, if you look at the right side of this chart, it is the dual mobility bit, which was a game changer. And there is a reason for that. So 15 years ago, when we started doing these with the single mobility prosthesis, it was one of those first hit surgeries. You know, you ended up with a bloody nose, because if you didn't get it absolutely right, you had these very early dislocations. And that's where the dual mobility comes in. It was a paradigm shift. You didn't get that issue right at the beginning. And because of the fact that it had a really safe learning curve, essentially what we've ended up is with more and more people taking this on. This is what the dual mobility prosthesis looks like. You have this plastic spacer in the middle with 2 pieces of metal on either side, and you have movement that occurs at both the articulations. There have been lots of papers now that confirm that the rate of dislocations has significantly reduced, and you can see how much it has gone down. And in part, it is because of the increased jump distance for the same neck length. This makes the joint very stable, and this is what we call a restrained or constrained cup in a manner of speaking. The other thing that it also does is it shares the load. So you have the shear being shared between the first articulation as well as the bone. And theoretically, this would mean effectively that the loosening would be less. But it also means that you have this little piece of plastic being crushed between 2 large bits of metal. You can imagine an 8 millimeter cup when you use a Maya is only 1 millimeter thick. So who knows what's going to happen in the future with this particular form of articulation. And this is where the plastic comes in. And it's going to be interesting in the future to see whether the ultra-high molecular weight polyethylene, which is used by some manufacturers, or the highly cross-linked polyethylene wins in this particular race. Because obviously, if you take the latter, there's a significant expense. We are also doing this in younger people who are very active, and you see newer complications and issues like intraprosthetic dislocations. Our lower limb consultants have shown us that with dual mobility prostheses, you can get notching, which is something to look forward to. And I'm going to be speaking with one of our engineers from Leeds about the dark side of dual mobility in our Birmingham meeting soon. But look, this is where we are at with the survivorship. So on paper, things are really going well. Those look like lower limb numbers. You have 93% survivorship at 10 years. This is incredible in terms of hand and wrist replacements. This hasn't happened before, and this is with the French and European figures, people who are doing single mobility replacements. Still very early days. Research is a little bit limited when it comes to dual mobility, so we mustn't confuse the literature that is there with the literature that has already been published. So we are still at the 3-year stage, and I would probably say there's nothing to be too excited about at the moment. The only thing that has changed is the fact that the procedure has a wider base. There are more people who are doing it. The question that's in everyone's mind is, trapezectomy is cheap as chips. A total joint replacement costs a lot. Is it worth doing this procedure? Do the ends justify the means? There have been lots of these little trials, case control series, retrospective studies that have come and gone, but they've been poorly designed and really not worth quoting, to be honest. The only series which was properly numbered and well matched, unfortunately had to be abandoned because the implant had a very high complication rate. We seem to have missed the opportunity in the UK. We have the SCOOT trial, which is now a 3-pronged trial. The surgeons just simply wanted to know which is better. And now what we have is a 3-pronged trial comparing conservative management, where they're going to do a non-inferiority type of analysis with trapezectomy, and then they're going to clump both trapezectomies and joint replacements versus enhanced non-surgical management. So we may not get the answer that we want, and we will have probably burned through 5 million or so of the taxpayers' money. But that's where we're at. There is an extended learning curve, very, very simple issue. So we do tend to use our palms when we get up. So if you don't cut your stem appropriately, you can end up with a problem. You can see how it dislocates. So you just take a little bit from the side off, and the dislocation stops. So attention to detail and doing this appropriately in a stepwise manner is crucial. So in theory, if we had left this the way it was, every time this lady got up, there was a chance for her to dislocate. So it's very important that you pay attention to a careful surgical technique with precise instrumentation. The trapezial fixation is extremely important with an extensive soft tissue release when appropriate. We've started doing these volant. This was something that we did because we used to do our trapezectomies wide awake with no tourniquet. I've stopped doing that because this prosthesis is so stable that there's no real benefit. So it's now done under a block. And to be perfectly honest, I don't think it really makes a difference. Extended indications with these collapsed metacarpals seem to be working well. But again, this is an extended indication. We don't really have the figures yet to tell us whether or not this is going to work in the future because of the long lever arm. But we do know that if things do go wrong and you have to take the trapezium out, patients seem to do as well as trapezectomies. One big cohort of patients that has suddenly started being referred across to a lot of tertiary units is the failed trapezectomy. Perhaps we are more conscious of it. Over the last 2 decades, we've done everything possible, like I'm sure a lot of you have. Fusion of the first to second, we've tried using the lasso and fusions, and patients really don't seem very happy at all. So we are trialing the Swimac bridge prosthesis. The inventor is Greg Packer, who over the last 20 years has performed a vast number of these. So he's done about 12 to 14. It's not a very common presentation, and a lot of these people have had a number of surgeries before, so they're quite a special group of people. Unfortunately, he hasn't published his work, so we are taking this through a national trial. As you can see, this can be a major problem, and this particular assessment was done under an anesthetic because of the pain. So this is what it consists of. It looks like a Motec wrist. You have an artificial trapezium that sits under the metacarpal, and you have a metacarpal stem that goes into the second metacarpal, and you screw the whole thing together, and it looks a little bit like a medieval torture weapon. Beyond compliance, we'll talk about that later. Currently, this is on limited release with only 3 centers undertaking it under license, special license within the UK with no published results. So currently, what we've done is we've created a national framework and we proceeded to collect data. I've done 9 between Feb 24 to March 25, so it's very early days. And these are some of our early results at the end of a year. So the earliest one is 14 months out since we performed the first bridge procedure. So significant improvement in the PEM and the quick dash. We've had 2 failures which have pulled down our grip and key pinch strength. Generally, good satisfaction so far, but we've had issues with insertion of the stems into the second metacarpal. It's quite an awkward angle, and if you don't get it right, it becomes loose, and you end up with a major issue. Because it's quite an extensive exposure, infection can be also an issue. So this is this lady at 8 months. She had an adducted thumb lying in the palm, and you can see she appears to have done quite well. This is the size of the incision. So you have to approach the second metacarpal as well as the first metacarpal and ensure that you pass that bridge underneath the EPL and the ECRL and ECRB. I've stopped doing the Z, and what we do is 2 longitudinal incisions to try and see if we can reduce the amount of dissection. As you can see, getting into the second metacarpal can be quite tricky, and this has been one of our learning points. We've also found that they're not entirely very stable. We've got used to the dual mobility prostheses. We've forgotten the pain of single mobility thumb replacements, and hence the stability itself doesn't feel quite right. And I think more likely than not, once we get used to the way it feels, we will start putting them in a lot looser. So far, so good, but it's very early days. I'd just like to reiterate that. Going forward, the plan is to optimize the design. We'll probably end up with dual mobility here as well, with an offset neck, and we do need to follow these up very, very carefully under the Beyond Compliance framework. Scapho metacarpal arthroplasties. This is something that we haven't tried. My biggest concern is that you have 2 mobile bearings. The metacarpal moves as well as the trapezium, not so good, and you could end up with problems. Moving swiftly into wrist replacements, you have a very similar looking timeline, and things improve as technology improves. We've been involved right from the beginning with Bob Beckenbauer's biaxial wrist replacement, which unfortunately failed, and I wrote up the salvage methods used with this particular implant. Going forward, we then jumped onto the universal bandwagon, starting with the universal total wrist replacement, the universal 2, and the latest iteration, which was the Freedom. So the universal 1, this is the first design of this particular kind with cobalt chromium radius and a titanium carpal base plate. This was toroidal in nature, and it had lots of areas where the pressure was not evenly distributed. So with the universal 2, it was changed to a different shape, which is the ellipsoid, with a number of other changes with the screw directions, which was supposed to improve the results and the survivorship. So we were sitting quite pretty at 7 years, 91%. We were really pleased with ourselves. This was going into COVID, 2019, 2020. Within the 2 to 3 years when we were off during COVID, Ian Trail, one of my colleagues, noticed a signal, and we had a large number of people presenting with osteolysis. So we did a deep dive. We collect all our data as part of a prospective service evaluation audit and looked into every single wrist replacement, and we were able to identify 76 of the 85 wrist cohorts. Now, this usually happens because we have a tertiary practice and people come from far and wide. And we found that there was a significant and serious problems that were occurring after the 7-year follow-up. And effectively, the survivorship just falls off at 7 years and drops from 91 to 77 with huge amounts of osteolysis occurring with breakdown of the plastic on the ulnar side. So this is what it looks like. The wrist fails in ulnar deviation and flexion, and the ulnar part of the plastic wears away. And I was truly heartbroken because I was at that cusp where I was perhaps doing the largest number of wrist replacements. This was going to be my thing. And I was really disappointed to write that paper. But, you have to write negative papers when required and inform people that, look, things aren't quite right. And this is what happens. Very quickly, you lose huge amounts of bone, and this lends itself to a very complex wrist revision. So I'm not going to go into too much depth here because I have a talk on this later on, which I hope you can attend. One of the problems that we realized was that the plastic that was used in the Universal 2 was irradiated in air and not in inert gas, and this is probably the reason why we had this problem. So these issues, I'm told, were addressed with the Freedom, which is the third iteration that Randy Bindran, Brian Adams, they were the clinicians responsible for this, and we put in quite a few of the freedoms as well. We've identified 12 implants, of which we only needed a revision in one so far. We are nearing the 10-year stage with the Freedom, because during my tenure, the Universal 2 had almost been withdrawn. So one of the holy grail, as it were, of wrist displacements is the center of rotation, and we need to get the center of rotation as close to the normal wrist. And you find that there is a significant translation when you compare the native wrist to a total wrist replacement, particularly with the Universal. And this is added to the sliding rotation and translation that occurs, which results in early failure if we don't get it right. So currently we are in the process of re-examining our Freedom cohort to see how things are going, and we've had to shift to the Motec wrist for other reasons. The remotion, Michel Beckstein has published lots of good work showing a survivorship of 90% of 5 to 9 years. And this is Daniel Brown's work. I think we spoke, Dr. Berger spoke about this, with the 78 to 86% survivorship at 16 years. Now, one of the things that the remotion has that the Universal doesn't have is a spacer that moves. Essentially what it does is it rotates an ulnar deviation posteriorly, and it decompresses the ulnar side. And I strongly suspect that that is the reason why you don't get the same type of wear that you get with the Universal, and it has stood the test of time. Currently, because of MHRA and MDR issues, the Universal has been withdrawn. They will not be selling that anymore in the UK. The remotion is all but gone. We have to force Stryker to supply us with the prosthesis when we need them for rheumatoids, and the Motec is the last one standing. I find that it is a very intuitive kit. I've enjoyed doing the Motec. There is definitely things that you need to learn even as an experienced total wrist surgeon. The inventory is small, the instrumentation is small, and there's excellent support with the company. I also work with Swimax, so you shouldn't believe anything I tell you. The Motec has been Ulla Reichsted's brainchild. This is something that he's done coming through the years as an orthopedic consultant and while he was training. Effectively, his paper, which he's published some time ago now, shows a survivorship of 85 to 86% at 10 years. And I suspect once we are all beyond our learning curve, it's very likely that the survivorship, particularly the Motec, is likely to improve. As far as our cohort is concerned, we haven't had any problems with osseointegration. We haven't had any osteolysis or metacarpal fractures. We do have one case from elsewhere. We've had issues with soft tissue balancing and bony impingement. I have restricted the use of the Motec just to osteoarthritis at the moment, because I think the degrees of freedom that it allows probably are not conducive to the rheumatoid arthritis. So this is a good case with fusion on the other side. He wanted a wrist replacement. You've got to get your wires centrally. Very often the stem follows its path, and what we made an error was with this area in the front, a large osteophyte which produced problems. And as you can see, it hinges out. And if you use a small neck, which is something which they've said that we should not use at all, instead of it hinging on the osteophyte, it would then hinge upon the cup, causing exactly the same problem. So we had to go in from the front, excise it, and this chap did extremely well. Another case where from St. Elsewhere's, they didn't put the metacarpal in deep enough, a metacarpal fracture, then lots and lots of metallic debris because they used a metal-on-metal articulation, and then you have to follow through with a complex fusion. So attend plenty of cadaveric courses, do double operating if required, select your cases carefully, and be prepared to follow your cases up. We invited Scott Wolf. Essentially, he has devised the kinematics wrist where the plastic is on the correct side. So if you were to reduce a wrist replacement and extrapolate it to the hip, the equivalent of the universal would be to have a stem made of plastic and acetabulum made of metal. So you shouldn't really be surprised that it doesn't work in the wrist. And what Scott, I think, has got right is he's put the plastic on the concave side. So that's a good thing. So far, again, very early results, and we are looking at interest to see whether they release that within the UK. And if they do, this would probably be something that I would like to do for rheumatoid patients. Comparing arthrodesis with arthroplasty, these are historic papers, 50% complication rate. There's not a lot we do in hand surgery that has, a 1 in 2 complication rate. Over a period of time, we've become better at doing both procedures. This is what the scoreboard looks like, and unfortunately, wrist replacements are at the bottom of the class, even if you use 85 as a 10-year figure with the MOTEC. And this is what the scoreboard for all the wrist replacements looks like. The Maestro, which had the best figures, 95% at 8 years, has been mysteriously withdrawn. So unfortunately, we do not have access to that. And this is a sobering picture which shows you that essentially what we do at 10 years is what the hip replacement performs at 25 years. So this is the Wrightington figures for some of Chanley's original and Dr. Murphy's original hip replacements. And I think to a large extent, this is because of the intercalated row and the complex mechanics around the wrist that cause issues. So moving quickly into the lunate replacements, the pyrocarbon lunate, this is something that we published in your journal, I think, the Journal of Wrist Surgery. We've done 9 of these now at Wrightington using the pyrocarbon lunate. Making the lunate is not difficult using 3D technology. Essentially, there are 2 holes, and we thread it like a pearl on a string and use an FCR graft and a synthetic tape to hold everything together. And this is our longest standing patient at 9 years who's delighted with the results of her surgery. They're predominantly female. This is what it looks like intraoperatively, and subsequently, every single patient develops this problem with the scapholunate tether. And this is something that we need to work on. So they do not want any revision surgery. This is the best the wrist has been for a very long time. It's done in end-stage Kienbach's. And I was really delighted to see Greg's work earlier. I just took a few screen grabs about the sweet spot, the isometric spot. So there's something there that needs to be looked at going forward to create a sloppy hinge between the scaphoid and the lunate. Because if it's too tight, you won't have a scapholunate break. Essentially what happens is the scaphoid fractures, and that's not a very good thing either. So there's probably some work that needs to be done looking at this fantastic work. Moving on to the ulnar side of the wrist, we find that due to the huge amount of education around the directs, the fact that it shouldn't be done, etc., we're finding less and less issues. Certainly with my generation, the incidence of Druge osteoarthritis is very low. So we looked at our historic series. This is being re-examined again for a 25-year follow-up. And we published our results in 2014, 74 patients, quite a unique mixed group who had a number of procedures before and following surgery. Quite a few of them went on to have what I call tinkering surgeries to get things just right. Looking at the survivorship, and this is what a lot of people have identified, is that once you get over that troublesome period of a couple of years initially, everything plateaus and people go on to do well. So if it's not a post-traumatic problem, if they haven't had major Druge ablations and instability, and if they're not very young, and you've chosen your cases properly, they tend to do quite well. But range of movement, particularly as regards supination, is not really something we can guarantee. And there are problems. I probably include one more group in that list, and those are people with hypermobility who do really badly. And then you have to revisit the sins of your forefathers. So we have all these patients very carefully documented where, because we didn't have a checker necessarily at that time or other instruments, other prostheses, we had issues. So as you can see, you had impingement. There were extended indications where you get pericollar osteolysis and curved ulnae where things went wrong. One of the problems with doing fusions of the wrist using pins is migration, and it can result in significant problems. If you ever do an ulnar head replacement, ulnar shortening, it's important to know that the shaft gets completely consolidated, and you need to put a K-wire down that and drill using graded drills. Otherwise, you're never going to get that ulnar head inside. The other thing is, very often, the shells that form are so robust and sclerotic that even that fails, and in those cases, you need to cut the prosthesis. So we pride ourselves at Wrightington to be able to cut anything. So we always have your friendly cutting pliers handy. You just have to be aware that when you cut them, it comes out like an 8mm ordnance. So you have to clear the room and make sure it doesn't hurt anyone. So osteoarthritis can occur at the druge accompanied with wrist arthritis, and because of the change in design with wrist replacements, this can cause issues, particularly with the freedom, with the point of insertion and the flare. And there have been problems in the past where the race begins with the rheumatoid cases where we've done these patients. So these patients follow up on a regular basis, and there isn't any easy solution. So revision surgery is really very important, and we've got a large number of people here from the Indian subcontinent, and this is the chakra view. So you have to know when you do these procedures that you don't end up like Abhimanyu. So if you go in, you need to be able to come out. So he clearly didn't go to the right fellowships, and he ended up with a sticky end. So we'll talk a little bit about what to do when these things fail. And this is Dean Soterenianos' tendon allograft, which we've done a few in the past before we had access to the checker. So this is a chap with ulnar head replacements, lots and lots of problems. He'd had many procedures. I did a proximal ulnar shortening, still continued to have a significant amount of pain, and we then decided to proceed with taking the ulnar out. Now this prosthesis does not come out, so you have to be prepared for carnage. What I tend to do is to pre-plan a window. So you make a rectangular window around the shaft, and then you flip it open, leaving one periosteal attachment intact. And then with curved chisels, you go around it, and it comes out. So if you plan this properly and you have the right type of instrumentation, it is not really an issue. But if you don't, you can end up with significant issues. So this is your allograft. Roll it up, truss it, like as tightly as you can. It needs to be really big, and then using these anchors, you put that trussed up piece between the ulnar and the radius, and this is what it should look like. And this is the result in this particular chap. He's 10 years down, and he's done really well. Don't think of doing this when you have a mid-forearm problem, because it can result in divarification and significant issues. This is another case chap who had a Kapanji procedure, and then successive generations took out more and more of the ulnar. John Stanley did a vascularized fibula, and then because he had ulnar-sided pain, that is an ulnar head replacement through a vascularized fibula. So when I inherited him, things were going on well. Unfortunately, he was in a wheelchair for various reasons. Essentially followed up every year. And you know what was going to happen here. He had a periprosthetic fracture. Tried to see if it would heal with conservative management. Didn't really succeed. So we put a plate in. It wasn't that difficult to put the plate in, but essentially over a period of time we realized that this was going nowhere and it didn't heal. He'd been a smoker in the past. So once the plate broke, we then went in again, and this time I put through everything I had at it. And fortunately, over a period of time, it did go on to heal. And I rang him over the phone and discharged him. But then he came back like a bad penny with a fracture of the opposite side. And you know exactly what's going to happen. That went into a non-union as well. And we then had to use an ulnar shortening plate to put it all together. So a little bit on one bone forearms, because this is another thing which we found was quite useful in these cases. So patient with an Adams procedure, which was very unstable, really quite important, even if the elbow is not an issue, to try and fuse both sides, because that's the way you get a solid post for the hand to act on. It's quite important to know that the radius, particularly proximally, does not approximate to the ulnar and the gap doesn't shut. So that disc of radius we tend to use to cover that gap. The distal part is quite easy. You can bring the ends together through a simple dorsal incision, but look at the problem proximally. So don't try and bring both of them together. Fill that up with bone graft. Spend a bit of time counseling them. So if it's on both sides, you need to know which side of the neutral they want it fused. As long as you choose your patients reasonably well and they've been in pain for a reasonable period of time, you will end up with a good results. It's managing expectations that is very, very important. So if any of you visit the Lake District, which is a very popular destination, this woman works at the Lakeside shop in Windermere, so you can go and say hi to her. As far as movements are concerned, remember pronation is something that with which you interact with the universe. Supination is self-care. So if you use loose supination, you're a little bit miserable. But if you lack pronation and you can't do what you want to do, you can be suicidal. What has been a game changer in the past few years, and certainly we are still at double digits, we've not done huge numbers, is the Shecker. So when presented with these unstable ulnae, we've started doing a lot of these prostheses. I find the team is very helpful and the results are nothing short of incredible in the right cases. So this guy is a red belt, judo chap, highly respected in the profession, who's gone into coaching, obviously. He's not doing this anymore, with a very good result. And we've had quite a few of these in these type of cases. We have extended indications, so you have someone with a Kapanji procedure with a very generous ulnar excision. So looking at this, when we did the planning, we found that we would have to take too much of the ulnar off, and we probably may have to do something like a custom Shecker for this particular person. But do not try to do the HOS, do not try to use Dean's method for this. Another case, which this is something which is commoner than you think. You know, it's ulnar dysplasia, where you have the ulnar doesn't grow enough, and it looks deceptively like a simple druge. But when you look at it from the lateral, you can see that there's a curve in the ulnar. In the past, we've come to a sticky end putting these straight prostheses down. So I thought we'd do something different. Putting a Shecker was something which probably wouldn't work. So Louis was not particularly happy with this, because as you can see, the prosthesis is sitting dorsally, which means every time she tries to pronate and supinate, effectively the captive head is going to try and pull the radial base plate out, which will result in major issues. So with her, we have decided to go with a custom implant using a material called as PEC, with a curved stem, which we'll introduce into the stem. It's relatively easy to do a unipolar ulnar head replacement. You just need to plan adequately. One of the issues that we are trying to discuss right now is whether, because of the translocation of the lunate, whether there's a significant amount of pain within the wrist joint itself that is causing an issue. So it may be that we replace the ulnar and she continues to have pain, so we may have to correct a bit of the tilt of the radius as well. So in conclusion, I think when it comes certainly to the wrist, if you were defining something or designing something which would work, it's really important to focus on a very clearly defined pathology. You need to make sure that that pathology causes significant amount of suffering. It's important to use a user-friendly approach in terms of the steps as well as the approach. There is no point in inventing or devising something or having to do something which only 3 people on the planet can do. The procedure needs to be scalable. It needs to be done by people relatively easily with a wide margin of error. And if you do that, it's more than likely that your procedure will succeed. And we've had problems with the wrist where the inventor does get great results, but then when you scale it out, particularly with finger replacements as well, it doesn't work quite as well. I'd like to end with paying my thanks to John Stanley and Ian Trail our founders, one of the things they used to say, John Stanley loved saying, was that we are all lying in the gutter, but some of us are looking at the stars. And I think this resonates with your mission, Greg and Jeff, with the APWA. You're advancing the boundaries of what is possible in one of the most intricate and challenging areas of the musculoskeletal pathology, which is the wrist joint. And both John and Ian have left behind a very rich legacy for which we thank them for. So thank you very much. Thank you for letting me do this oration. It is truly an honor and a privilege. Thank you.